So I hear you have this crazy idea that paramedics should be treating patients with AFib RVR in the field. That's nonsense. What makes you think this?
Well, we were able to look at an ESO data set and determine that patients spend less time in the hospital because they get discharged from the ER more frequently instead of being admitted, and they have a lower mortality rate. So if you think that's crazy, then yeah, I guess it is.
Wow, maybe I have to reconsider this.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we, Mikey, what do we do here?
Well, we shine the bright light of science on the darkness of EMS clinical practice.
We do shine that bright light on the darkness of clinical practice. And I'll tell you what, I have not talked about where that tagline came from in a long time. So I figure I should do it.
Let's do it.
We are sitting here live in Ashland, Oregon.
Indeed.
At the State of Jefferson conference. Wonderful conference. If you've never been, you need to. It's an amazing conference. Wonderful people. Beautiful area.
Yeah.
Well, I was along for the Mikey show, and we talked about podcasting.
Yeah.
And I hadn't told the story about where the name of the podcast came from in a long time. And it came from us drinking bourbon. Cheers, my friend.
Cheersies.
And after a few of them, I got inspired by my favorite author, Carl Sagan. He wrote a book called The Demon Haunted World, Science as a Candle in the Dark. And because of that book, I and the bourbon decided that maybe the mission of the podcast to be to shine the bright light of science on the darkness of modern clinical practice.
I love it.
Mikey, do you know an area of science that is really, really dark right now?
I mean, there's a lot, but if I had to guess, I would say it's probably the treatment of Afib.
My God, would you really?
Yeah. I mean, it's pretty controversial in the industry right now.
Wow.
Like, what do you do? Like, do you shock them? Do you give them medication? Do you send them home? Do you, I don't know. It would be great if there was some research on that topic.
Wow. That is an amazing segue. It's an amazing coincidence, too, because I just happen to have a paper here that I want to talk about.
Well, it's perfect.
Yeah, well, let's jump into it, shall we?
I'm ready.
You know, we started this episode off with it was kind of a fun little thing with Christy O'Neill, where she was talking about why the treatment of AFib RVR, rapid ventricular response in the field, is important.
Yeah.
And what we said, for those of you who can't see it, I asked her in jest, why should we give a damn about patients with AFib RVR? We can just take them to the hospital and they'll do fine. And her answer was great, as you will see there. It said, well, if you don't care about ED length of stay, if you don't care about mortality, if you don't care about rate control, then sure, drive them to the hospital. Well, she was a member of a research group at a research forum, the Prehospital Care Research Forum.
I've heard of that before.
PCRS, amazing group. And, PCRF, ESO teams up with PCRF. Yep. Where I shot that video of her was at a PCRF in Salt Lake City. Gorgeous. Me and Dave Wampler stayed over an extra day, went and skied.
Oh, yeah, that's right. I saw the pictures.
Oh, my God. Hadn't been
I'm glad you didn't break anything.
It was the first time I've ever skied in Utah. There was powder. I'm a skier that skis in mostly hard-packed snow. I didn't know what the hell to do when I hit powder. It was kind of fun. Well, Christy was there. We were at this PCRF, and I remembered, and I said, you did a project at PCRF where y'all came up with this concept. You took the data, you worked with a statistician, you answered a clinical question, and by the time that by the time that session was over, y'all had an abstract Well, they actually did the next step. They did the hard work to turn it into a manuscript.
Awesome.
It got published in PEC at the end of last year, and it is a truly amazing paper. So let's talk about it a little bit.
Okay.
The name of the paper is, if I can read it here we go. Pre-hospital intervention improves outcomes for patients presenting an atrial fibrillation with rapid ventricular response. The lead author is Fornage. Christy O'Neill was on there. Dowker, Wanta, Lewis, and our buddy Lawrence Brown. Lawrence Brown was the statistician who helped them at the PCRF. And boy, when I'm reading this paper, I can see Lawrence droppings all over it. This is a really, really well done paper. It's a well written paper. It's easy to follow. And they looked at this and they said, what are the criticisms we're going to get? And they addressed them up front. It was wonderful.
I love that.
This was published in Prehospital Emergency Care, as I mentioned, 2023. It is still, you get these things off the press, which means that it's great you get the evidence early, but it really jacks with your citation. So I don't have the full citation. I'll drop it in on the YouTube video. Let's run through the PICO question, shall we? So this was a study that used the 2021 ESO research data set, and they used this thing called propensity matching.
I've heard that term.
Now, a few episodes ago, I might have been discussing a bad use of propensity matching, how it was used in the head-up CPR papers.
Yeah.
Incidentally, the editorial that I was working on has now published. My co-authors and I, so I want to give a shout out to Dr. Michael Sayre, Dr. Rimley Crow, Dr. Jim Menengazi, and Dr. Henry Wang. We worked on this editorial to really say why we don't think it's ready yet. And their use of propensity matching, we feel, was inappropriate to answer the question. And the reason it was inappropriate is they took one data set collected at a different time in a different place for a different reason, and then tried to compare that to another data set 10 years later.
I see.
For a whole different thing to try to control and figure out what the implications of an intervention that all patients in one data set got and no patients in another data set got. So I don't feel like that was an appropriate use of propensity matching. So in brief, propensity matching is where you basically say, there are differences in the patients who got treated and didn't get treated. So we'll talk about it in this case in atrial fibrillation. They took the ESO data set and they broke it into two groups, those who got an intervention and those who did not. Mikey, you probably see a lot of patients with AFib.
Well, back in the day, I did, for sure.
You did?
Yeah.
Did you give all of them treatment?
No. In fact, we really, unless there was, the classic, blood pressure issues, altered mental stat. We didn't do anything.
Unstable.
Yeah, we had
That's all you did.
Yeah, we had unstable.
Stable treatment.
Nope.
All right.
Nothing.
So, but you cardioverted some patients and not others.
Yep.
So you could say there was a fundamental difference in the patients who got treatment and those who didn't.
Yeah.
So you might have seen, say, a 65-year-old female, long-standing history of AFib on anticoagulation, who she forgot her beta blockers.
Yep.
She's in AFib, her heart rate's 150, her blood pressure is 50, and you're like, zeet,
sorry.
ride the lightning.
Yep.
A zapper.
Yep.
But you might see another patient with AFib RVR, also heart rate of 150, but their blood pressure is, say, 120. You don't zap them.
That's correct, sir.
Fundamental difference between the two groups. So propensity matching, like logistic regression, is another way of trying to control for confounding variables. That is something that impacts the outcome of a patient other than what you're trying to study.
Okay.
So propensity matching, in this case, took those patients with AFib RVR that got treatment, and let's say patient number one is a 62-year-old female with a heart rate of such and such, no comorbid conditions. The blood pressure is 120. They don't have all these other things and no other medication. And you took them to hospital X and you happen to give them diltiazem.
Okay.
Well, they will match that to another patient that's 65 years old with a long-standing history of AFib, RVR, whatever, everything, including the hospital they went to, is the same, except they did not
Get the intervention.
So in order to do that, let's say you have 300 patients that get the intervention, you need a much bigger sample size over here to draw from.
Okay.
Fortunately, the majority of patients with AFib RVR don't get treatment, so they were able to do that. So that's that one-to-one matching. They used the exact same data set, therefore it's an appropriate use of this. Still not a randomized controlled trial,
Right.
but it's pretty good.
Funny enough, we actually looked at our AFib RVRs in our system. This was probably 2013, just because we were trying to figure out, do we need to add a medication to the box to treat it?
Yeah.
So what we found was there were, and I'm going to make this number up, but the ratios is going to be the same. That we had 3,000 patients
Okay.
over 4 years, and exactly 0 of them went code 3 to the hospital, or had an otherwise life-saving intervention performed on them. There were a few that got cardioverted,
Okay.
but a majority of them just went to the hospital.
Now, that's not surprising to me since you said you did not have the ability to do anything other than cardio.
So we were
in
looking
your
at
protocols.
where they transported lights and sirens back to the hospital because they were so unstable.
Okay.
So
Yeah, so assuming you are not indiscriminately using lights and sirens, which is bad.
yes,
we
which
know
I'm
why.
100% sure happens. Do you think?
I think this is a confounding variable. I think this is a great concept here. But the only reason you're going to go lights and sirens to the hospital is they're really sick. And the indication for going zap is they're really sick. So why would we be surprised that we don't go lights and sirens to the hospital very often for patients we don't go zap on?
Well, even patients that get zapped and that are doing better still end up going code 3 to the hospital because we just did this thing. Oh my God.
yeah.
What if we got to do it again? I mean, it was a different time. It was 10 years ago,
Yeah.
at least. But anyway, I just thought it was an
Did
interesting.
you go lights and sirens to the hospital on a patient you had already successfully intubated?
Well, of course.
Because they're sick, right? Let's just overlook the fact that you've already taken care of their time critical emergency. You've managed their airway. Guess what?
Emergency's
Poof.
over.
No more emergency.
Yeah. It's
Take
pretty
your time.
wild.
Be careful.
Yeah, we're getting off track. But yes, same idea.
Oh, it's I love this topic, right?
Yeah.
All right. So that's their methods. ESO 2021 research data set. Those patients who got it, didn't get it, they used propensity matching. Their population. Let's do the PICO question. These are adults with an initial rhythm of atrial fibrillation, and they had a heart rate of greater than or equal to 110.
Okay. Where did they
110.
find? Where did they find 110? I mean, I've
The heart rate?
sat. I know I've sat in these, but
Oh, I'm sorry. You mean why not 109?
Yeah, why not
Yeah.
117 or 26 or 170 or whatever?
Interestingly, they referenced some AFib guidelines, which I didn't know about. I will tell you, if I see a patient in the ER with a heart rate above 110, I'm going to treat it. Now, I'm assuming that they came to the ER for a reason. In
Yeah.
other words, they're symptomatic.
Sure.
If you're at home with AFib, you always have AFib and your heart rate jumps up to 110. I don't know. You just get up and
Yeah.
move around, watch
Right.
it for a little bit. If it goes down, leave it alone.
Yeah.
But apparently that's in guidelines.
Okay. Well, I was just curious.
It is interesting because if you're going to write a protocol for the treatment of RVR, maybe you would use a higher number, right?
Yeah.
So maybe if they used 150 instead of 110, the results might have been different.
100%.
They did a sensitivity analysis using 150, just to be clear, because, Dr. Brown, smart guy. These are all smart folks. This is one of the reasons I really like this paper. A lot of different analyses. So you had to be an adult greater than 18. You had to have your first ECG was AFib.
Okay.
Not a first ECG of sinus and then AFib, because that clouds the picture. Really? Was it really AFib then?
Yeah.
Heart rate greater than 110, transport unit only. So the reason they did that is we don't want to double dip.
Oh,
ESO
okay.
is a
Sure.
per encounter data set, just like Nemesis. So you could have multiple records. Didn't want to do that. Now, they also addressed one of the big problems. When I took over the system in Fort Worth, what I learned is my predecessor had removed diltiazem for the treatment of AFib RVR, and I asked why. And they said, well, we were misdiagnosing patients. We were treating an awful lot of sepsis that really had sinus tach and they just needed fluids, or they had AFib RVR, but their underlying problem was sepsis, and you gave them DILT and started them on a DILT drip,
And then they
that
crashed and they died,
Right.
whatever, yeah.
In this paper, they excluded trauma, hyperthermia, so a fever, hypothermia. I'm not entirely sure why, but they did. I mean, I'm not questioning it. I just don't associate AFib RVR with hypothermia, but maybe they had a reason. They also excluded sepsis, and then if there was an out-of-hospital cardiac arrest prior to arrival. So if AFib was your post-ROSC rhythm, that
count.
is just give that shit time and it'll probably settle out. So different thing. So that's the population. Their intervention was you did rate control. Their control is you did not do rate control.
Okay, easy.
And here are your outcomes. Number one outcome is ED disposition was home. So, did you get admitted or did you get sent home?
Okay.
And for the purposes of dispo home, if your home was a nursing home, so if you came from a SNF and went back to the SNF, they counted that as discharge home, which is
fair enough.
Probably reasonable. Secondary outcomes were EMS rate control. You were above 110. Did you get
Now
it
you're-
below?
now you're low.
I think they used 110. I'm trying to remember. They measured length of stay for those patients that had HDE outcomes. Remember, we're dealing with the ESO data set, something you're very familiar with.
Indeed.
ESO has, I think, probably the largest health data exchange. We have more outcomes with ESO. I think we're up to like 20% now.
Yeah, it's a lot.
Great data set. So you can get ED dispo, you can get rate control, you can get adverse events, but you need the HDE. Actually, you do need the HDE for dispo home, as well as length of stay. And then check this shit out, Mikey. They looked at hospital mortality. But did you die?
Yeah.
Great question. They looked at that. And then, the big reason not to treat is you're worried about creating a bunch of hypotension, right? I think you were just asking me, somebody was asking me earlier, hey, what about these new Heart Association guidelines? Oh, it's Peter Hossick.
Yeah.
Because, we are in Oregon.
Indeed.
Peter and Amber here.
Yep.
Howdy, Peter and Amber. So they said these guidelines say don't treat with diltiazem in the field because you don't know if they could have a low EF. Cardiologists really, really, really worry about this. And I think I don't know, I need to bring one on and talk about it.
Yeah.
But I think they're extrapolating the experience of don't put patients with a low EF on oral calcium channel blockers, put them on a beta blocker instead. And I think they're extrapolating to don't try to achieve rate control with an IV medication.
Okay.
That's my guess. I'm not a cardiologist. I should probably ask one before I say something.
Fair enough.
So that's what they looked at. Now, as I get into the results of this, what they found, I want to go a little bit over some parts of the paper. I want to start with their consort. They have this beautiful consort diagram, and they talk about a consort diagram is just a flow of patients. They started off total ESO data set of 911 calls with a ground transporting unit, 5.1 million
Yeah, I was
calls.
going to say it was going to be in the millions.
Big ass data set,
Yeah.
right? Now, the majority of patients don't have AFib. In this case, 5 million didn't. Okay,
wow.
get rid of those. Now we're dealing with documented AFib, 156,000.
Okay.
Now we're going to exclude 21,000 either because of age. They excluded age
The
over
trauma.
100.
Yep.
A couple reasons to exclude over 100. One is that there aren't many patients that are older than 100. And because of that, if you give their age and you include them, it becomes identifiable.
Oh, okay.
Also, it's if they're 150. I think the oldest patient I've seen in the data set was like 280 years old.
Oh, yeah.
Their name
happens.
was not Lazarus.
Yeah.
It was Fat Fingers.
Yeah, Fat
so
Fingers.
they excluded those. Young'uns they excluded. Cardiac arrest they excluded. So you can kind of see where they got those. They ended up with 135,000.
Okay.
And then they said, well, ultimately you had a couple more you had to exclude, another 96,000 because, well, they weren't in a RVR. They ended up with 39,000. And those were broken up. 33,000 of those had no intervention. 4,900 did.
Okay.
Well, that's all right.
Yeah.
That sounds like a good
Yeah. That's a
group
pretty
for
good
propensity
yeah,
matching.
for sure.
So they ran through these. I'd like to read, I'm just going to read verbatim, I'm going to put it up on the screen here. I very rarely read something, but I want to read this because I think this section, and I'll skip ahead a little bit because my slides are out of order. I note to self, I should change that. This just talks about why you should treat AFib. Let's just say that the results of the study were positive.
Okay.
This gives the most concise reason for propensity matching that I've come up with. I think they said it much better, and boy, do I smell Lawrence here, than I did in all of my whining about head-up CPR. Administration of pre-hospital AFib RVR interventions is not random. The decision to provide an intervention may be driven by both non-clinical and clinical factors. Whether and which AFib RVR interventions are available varies by EMS system. Further intervention will not be indicated and may specifically be contraindicated in some patients with AFib RVR. Thus, therefore, one concern is that untreated patients may be systematically different, Mikey, systematically different, either more seriously ill or maybe less seriously ill than the patients that were treated. We therefore use propensity score matching to minimize confounding due to such differences. Propensity score matching minimizes bias by selecting only untreated patients who are demographically and clinically similar to corresponding treated patients, thus approximating the conditions of random allocation.
I love that.
They said that very, very well.
Yes.
First off, they said approximating random allocation. They didn't say we don't ever need to do a randomized control trial again. Just to point that out. All right, you wanna maybe talk about some results?
Let's find out what they found out.
Let's get into it. They actually used something called an average treatment effect among the treated, an ATET.
Oh my gosh.
That's different than the big gangly thing in Star Wars.
Yeah,
That's
yeah,
an
the
AT or an ATAT. I'm a Star Trek guy, so
That's
I don't know if
terrible.
is it ATAT or AT-AT?
It is. Well, either way.
Okay.
Yeah.
I think people who say at
Yeah.
it's kind of weird.
Yeah.
All right. So they used that. Now, in this type of allocation, and I'm not a statistically significantly large enough nerd to tell you which populations the ATET does this in.
Thank goodness.
But in this one, it approximates a risk difference. So we're just going to talk about a risk difference. The risk difference here is the difference in risk between treated and
not.
untreated.
Okay.
Controlled for all of the things, and they controlled for lots and lots of stuff. All right, let's start off with EMS rate control. Among those who were not treated, only 18% had rate control. Well, not shocking, right? It just happened to happen. 41% of those who were treated, got rate control. That is a statistically significant adjusted risk difference, or ATET, 23% difference. The other thing they did is they gave a number needed to treat.
Okay, good.
Love me some
Yeah.
number needed to treat. Number needed to treat means how many patients with AFib RVR do you need to give the treatment to get one additional outcome? And in this case, it's rate control. That number is 5.
That's pretty good.
That's damn good.
Like, that's good. I think AEDs, we talked about this before, is like 1 or 2.
80s or 4.
Okay. I mean, that's so 5. That's pretty good.
Mikey, do you give aspirin? You're hopped on a truck tomorrow.
Yeah.
You have a patient with a STEMI. You going to give him aspirin?
You betcha.
Do you know you have to treat 46 patients? Oh, 47 patients, I'm sorry, with aspirin to prevent one additional death among patients having a STEMI.
That seems kind of odd.
At 47, that seems pretty high. Number needed to treat. However, we give the shit out of that because the number of 47 is actually pretty good. 5 is just way better.
Yeah.
All right, discharged home from the emergency department, 34% versus 38%. Significant. Number needed to treat, 26.
Okay. Still looking good.
I'm liking it.
Yeah.
Length of stay, not significant. Length of stay in the ED and the emergency department, the ED and hospital, excuse me, I'll get that right, not clinically significant.
Okay.
How about hospital mortality?
Curious about that one.
I mean, we're just treating the symptoms, right? We're making them feel better. It's not really going to save lives. Oh my God. Hospital mortality in the untreated, 6.7%. In the treated, it's 4.3.
Wow.
Adjusted risk difference, 2.5% lower. That is statistically significant. The confidence interval range goes from 4.2% less to 0.8% less. Number needed to treat of 40.
Wow.
Which is less than 47 with aspirin.
Yeah.
We're giving aspirin to all of our patients who might be having a STEMI. This gives you a pretty good rationale for why to do it. I was not expecting this. I did not expect to see a mortality difference.
How about things like hypotension and things like that? I would be curious about that. What's the incidence of that?
Would you be curious?
I am curious.
Curious. Curious. Well, let me help your curiosity, Mike.
Thank you.
Our cardiologists, they don't use diltiazem, and and if they happen to have low EF, you can't give them dilt because why? Well, because you can drop their blood pressure. Yeah. Okay, guess what? Those patients who got an intervention, remember this is not just diltiazem.
Yep, it's any intervention. Rate control.
Rate control.
Yep.
Or rhythm control.
Or rhythm
cardioversion
control.
will hopefully convert them. There was statistically significantly more hypotension in the treated group. Untreated was 7.2. In the treated, it was 9.8, 2.6% difference.
Okay.
Here's the interesting thing. They then went in and said how much of that hypotension was transient and how much was not.
So what was the
transient.
duration?
None of it was non-transient. And they defined that by were they still hypotensive at ED arrival? They were not.
Wow. Okay.
They gave them the thing, whatever the thing was, had a little bit of hypotension, a little bit more, 3% more, but it went away. Bradycardia, you got to worry about bradycardia.
Sure.
No significant difference.
Okay.
Why do we care about hypotension or bradycardia? Well, because they can combine
And lead to badness.
Yeah, and what's the ultimate badness?
The cardiac arrest.
Cardiac arrest. No difference.
Wild.
That's impressive stuff. Now, I mentioned they did some sensitivity analyses. So one was, well, maybe we only ought to be treating patients with a heart rate above 150. And I'll tell you, when I write my protocols, it ain't 110.
Yeah.
I require it to be a little bit different. They ran it again at 150. That improved rate control and better mortality, still there. And that's what we like in a sensitivity analysis. You do the analysis in multiple different ways and you get the same result. That's good. They had the same result. Now, in this case, they did see no difference in ED discharge. Still rate control and mortality. Now, the other thing, Mikey, is that maybe they're just treating sinus tachycardia with diltiazem, with labetalol, low pressure, whatever it is, Esmol. And of course there's no difference because they weren't in the damn rhythm to begin with. So, which was the problem with my system. That's what we were really worried about.
Yeah.
So they said, well, let's now look only at those patients that had HDE outcomes and had confirmed AFib either in the ER or the hospital. Now we know they have AFib.
Yeah.
Now let's rerun it. Same results. No difference. No difference in adverse events. Still lower mortality. So I'm liking this, Mikey. I'm thinking this is pretty good.
Sounds good.
What's my bottom line here, buddy? I think if you treat AFib with anything compared to not treating, you have better rate control. Patients like that, that's good. You have fewer admissions. You have better mortality. We don't like dead people.
No.
Fewer patients die, better mortality, no difference in meaningful adverse events.
Yep, I like that part.
I think that's a big thing, man.
Yeah. Especially the adverse events part. I mean, that seems to be the, and we're down to about 2,000 people in here, by the way. It's wild.
But I'll tell you, these 2,000 really care. I appreciate
the two that are still here. They're just like hanging in there.
The 2,000, you mean?
Yeah,
right.
2,000.
The 2,000.
Yeah, that's what I meant.
Yeah.
By the way, you should go check out Pocus Stuff on YouTube.
You know, you should.
Yeah.
I hear that's a really good channel.
Up and coming.
Check it out, man.
Yep, it's good. But yeah, no, I mean, this, it's clear that we should be doing something, right? And,
well, it's more clear now.
It's absolutely more clear. Yeah.
It really is. I moved up to Fort Worth, and it's always interesting to go from one place to another because the assumptions are different. I had a lot of assumptions, in Wilco. Why do we do it? Well, because we've always done it.
Yeah.
Why the hell wouldn't you do it?
Mm-hmm.
And sometimes it's really good to challenge those assumptions, because maybe I've been doing things for a reason that just makes no damn sense whatsoever.
Yeah.
I don't know. Maybe give an epinephrine in cardiac arrest. Maybe it's the right thing. Maybe it's not. I don't know. And
Yeah.
you're not going to know until you study it.
Yep.
They studied it. This is a great question. Really, I would recommend you read this paper. Very well written. They go in and they really address all of the potential challenges. Now, again, this is a retrospective cohort study. It's not a randomized control trial.
Yeah.
We really need to, I would love to see this confirmed in a randomized control trial.
Yeah.
Now, again, their groups, any treatment versus no treatment. So you could say, well, of course you're going to see a benefit because the only treatment was electricity. And the only reason we give electricity is they're sick as snot.
Mm-hmm.
And if they don't get it, they're not sick as snot. There's no snot.
Yeah,
There's no
snot.
sick. So of course you're going to see a benefit. 2% of these patients that got treatment got electricity.
Yeah.
That's not what they were doing. The vast majority, 98%, were with medications. The biggest class by far, yeah, wasn't even a class. It was just diltiazem. That was the only calcium channel blocker. Beta blockers were another 4%, whatever the difference between 2 and 87 is. So 87.5% got diltiazem. Really, this is a study about diltiazem.
Yeah, yeah.
And I think that is the key thing here. I think it's still open. They did any diltiazem. Doesn't matter how you gave it, they included it. I mean, you could have esmolol in here, sure. But I think this is really a study about diltiazem. How they gave it, I don't know. The system I took over in Fort Worth, they gave 0.25 milligrams per kilogram and then started an
drip.
infusion. That's not the way I did it at Wilco. I gave a little test, a little whiff of diltiazem at 10 milligrams, not because I thought that was going to get rate control.
Was it a hypotension?
It was, I wanted to see if it was going to drop their blood pressure. If
Yeah.
it didn't, then I would give them the real dose
Yeah.
at 0.25 milligrams per kilogram. If that didn't do it, well, that's all right. Go on to the hospital.
Yeah.
I think we have evidence here that treatment of AFib with RVR is something we need to be doing. I don't think we need to be afraid of hypotension, bradycardia, or cardiac arrest, because we just don't see anything other than transient, which just didn't,
Yeah.
I don't think something I care about clinically.
I mean, I think this is a great opportunity for the paramedics that are watching, and this is something we just talked about on the EMS show that we recorded a few minutes ago. So check out episode 32, which was
32.
which was Dr. Jarvis
Awesome.
and I. But you know, this is a great
Just to be clear, episode 32 of what, Mikey?
the EMS show. Yeah,
Like anybody who listens to the Lighthouse would not know.
I know,
Okay.
but I just want to make sure that's clear. But I mean, this is one of those papers that you should read. Take the notes from the podcast, and if you don't currently have something like this in your treatment protocols, this is a great opportunity to
Yeah.
go and talk to your medical directors. Hey, you know, I mean, it makes too much sense. I mean, this is a great study. Yeah, it's just good.
So I'll tell you what, I see Dr. Maia Dorsett here. Maya, we are at the State of Jefferson conference. I need you to come over here. Oh, that's even better. She's saying she doesn't know what we said, which makes this perfect. Maya, come here. We are.
Yeah.
Maya, you
Here,
need
I'll
on
let
this
her
end of the
slide into this
microphone
my spot right here.
because she has a line she has to say.
Oh, that's right. You're up.
Oh, you
In honor,
but I can't tell her too to shut the fuck
of
up.
course you can. Come on, they can't hear you.
Oh no, there's video.
You look beautiful. Sit down.
Yeah.
The 2,000 people, now 3,000 in the audience here are saying, get your ass in the screen and get up to the mic.
You
So-
look tall when I sit next to you.
Well, that's the first time anybody has ever told me I look tall. So, Dr. Dorsett, first off, you were here.
Dr. Sani.
I did not, but that's coming. So, we recorded this video. It's in a large room. It's much less creepy than the last one we did in my hotel room.
Yeah, that was
so
weird.
there is that. So we were recording an episode, and I think my favorite outtake of any EMS Lighthouse project was you. And Ritu was doing what Ritu does, which is bloviate. And what did you tell him? What was your line? Come on, I want to get this again.
Let him fucking talk for 2.
It was actually, yes. Amazing clip. You got to go watch that.
Just let him fucking talk for 2.
But welcome back to the EMS Lighthouse Project. So you are a medical director. You're a medical director in New York, which is it's one of the 49 lesser states, and y'all don't have delegated practice. You do have certain regulatory things that you have to deal with, but do y'all treat Afib, RVR in the field? Stable Afib, RVR?
Yes.
What do you treat it with?
We have 2 options. We have either metoprolol or diltiazem.
Interesting. Metoprolol, IV.
IV metoprolol, oral diltiazem, and actually under med control order, you can get amiodarone.
Let's say you did not give, your protocols didn't allow for Afib RVR, and you have a paramedic who comes in and says, listen, doc, I think we need to treat this. So in general, when you have a medic that comes to you and says, we need to do X intervention, what's your response to them? How do you deal with that?
So my response is, so I think it's one thing to say I have an individual medic and I want to do X intervention. I'm interested in the evidence that on a system level, I'm going to overall improve care for patients.
Okay.
I think this is one, right? So this is one study. So we definitely have metoprolol, we have diltiazem, but that's, I think, in a system that you have to be really careful how you roll this out. And if you say, okay, we have Afib with RVR, we treat this, because in the same time, this is coming in when there's an entire body of evidence, right, that when you have Afib with RVR, the first question you shouldn't ask is, are they like symptomatic from the rate? You have to ask why. Afib with RVR has a differential diagnosis. And when it was studied in emergency medicine patients, about 15% of them were septic.
Yeah.
And the other thing I tell my paramedic students is if I have Afib, I don't do sinus tach anymore. So, right, so that is a tachycardic response to an underlying pathology. So I give people the tool in the toolbox, but I don't want them to use it. I want them to be thoughtful about what is the differential diagnosis of why this patient is an Afib with RVR. Is this hypovolemia? Is this sepsis? Is this a PE? Is this
Sure.
like a big pericardial effusion? And once you've actually taken a good clinical history to say, I think the rhythm or the rate is the primary problem, not a response to an underlying problem, then I can go and treat it. Very rarely when I have these patients in the ED is the first thing I give a rate control agent, right? Like I think about it, sometimes they get some fluids because often it's sepsis. And then what I wish we would just add is they all carry magnesium. And actually the data for magnesium and making these other medications is much more effective.
It might be that we finally found a use for magnesium.
There's data for magnesium in reactive airway disease.
It's not as good as I would have hoped.
And eclampsia.
No doubt. No doubt. There is some.
So that would be so if I had to say what would be the first med I'd want given, because there is a reasonable data that the other medications is more effective. And if you think about the continuum of care, I'd actually add magnesium to the formula.
So your thing here, what we have devolved now into not whether we treat AFib or not, but what to treat it with. So I would argue that there are probably, this is a great concept on medical decision making. I would argue as an experienced emergency physician, you will walk into a room with a patient that shows up with palpitations. And by the time you walk out of that room, you're like, give them DILT, or we're going to treat it. You don't necessarily wait for a lot of lab tests to prove it, but your history taking, your differential diagnosis pops up. And I was always taught with AFib RVR that there's an I in there somewhere. You need to look for the I's. So infarction, injury,
probably
insemination, and intoxication.
Yeah.
We had to get pregnancy in there somewhere. It doesn't start with an I, so insemination is as close as we could get.
Yeah, never
so
heard
think
that
about
one.
those. Have you not heard the infarction, and
I did
injury?
not hear insemination with AFib with RVR. Never on my differential.
I will tell you, I've never seen a patient who shows up with the AFib RVR because they're pregnant. It just not happened to me, but presumably it
I
happens.
have, but they had a massive PE.
Okay, well then I would. God, there was another. Was it ischemia?
It's ischemia.
How would you get
It's
an
ischemia
I for PE? In claudication? That's like a Red Hot Chili Pepper song. That's not a. Impasse
Impasse?
sounds pretty good to me. Like it can't impasse the clot. So anyway, so your basic question here, to get back to the paper, when a medic comes to you and says, "Hey doc, I want to do this thing," your question is, well, what's the evidence? So let's say you don't treat AFib RVR with anything, regardless of how you treat it, and they bring you a paper that says, "Hey, this is an ESO study. We're dealing with 30,000 patients." Actually, I think the number was 4,000, 5,000. And it shows lower mortality in hospital with treatment. It shows that there is
So I'm going to say, what's the
better rate
selection
control.
bias?
Well, what do you mean?
So in general, so if
Great. So you're going to question the study.
right. So
Okay.
is there a selection bias? So for example, I have really.
And to be fair, you know nothing about this study. So you are reading
I-
this study to begin with, and you're asking these questions. These are the questions that you should ask.
Yes. So, right, is there a difference? Just like when we talk about indication bias for airway management and cardiac arrest and retrospective data, I'm also interested in, it's retrospective, this isn't randomized. So if a patient is presenting in severe sepsis with AFib with RVR, and I have a medic who's taken a good history and said, I'm not treating this with metoprolol, this is
Those were
severe
excluded.
sepsis.
So they excluded, I'll click back to my things here.
But that's a question I'm going to ask.
Absolutely. Well, it's a
Okay.
good question, right? So they
you're playing the part of
specifically
the medic.
excluded. I am.
Okay.
I am. Work with me here, Maya. It's a podcast. So trauma, fever, hypothermia, sepsis, and out of hospital cardiac arrest prior to arrival. Those were all things they excluded.
Okay, so that is actually an important exclusion criteria.
Yeah, it is.
Because this is retrospective data. So when I release a medication to say we're going to treat this
The
medication, right, into the wild, patients don't present with, I have palpitations, and by the way, I also have sepsis, or I feel lightheaded and I have AFib with RVR and this is sepsis. I have to trust that somebody takes a good clinical history, considers that this
Yeah.
is sepsis, and saying, so I think what you're saying is in
Is
the
that any
population-
different than any other patient population?
No, but this is one of the issues with saying I'm going to take data from a retrospective study
Okay.
and change my protocols and release it.
Sure.
Right? Because to me, like the rub is not whether or not if a patient is symptomatic with AFib with RVR, where that is the underlying, that is the issue, right?
Right.
The problem is due to the arrhythmia.
Yeah.
The issue
They
with
have
saying,
ectopic foci, not sepsis.
yes.
Okay.
But the reality is when you're taking care of undifferentiated patients, when I think about the harm of potentially treating patients with the wrong treatment.
So let me say you are worried
It's the
about.
diagnostic error of the why.
Okay, fair point. So you're not worried about the patients they know have sepsis. You're worried about the patients that they don't know have sepsis. If they knew they had sepsis, and sepsis is a contraindication to treatment, you're not worried about that. You're worried about the unknowns, right?
Yes.
Okay, fair point.
And I'm thinking about consideration of whether or not this is sepsis and the differential diagnosis and wanting, like there's so many things where
Yeah.
people want to make the number normal. And it's not about making the number normal. It's
Mm-hmm. Yeah.
about recognizing and treating the underlying pathology.
Fair point. So if you knew it was sepsis, they've excluded you from this trial, so you're not in there.
Yes, but patients don't
it's-
say I have sepsis.
You're right. But let's say maybe you would see a difference in fever. Well, they excluded fever.
What I'm actually interested in is what percentage of patients with AFib with RVR did
Mm-hmm.
this include?
So say that quick. Let me pull the paper up.
So of,
say the
so
say
of
the question
all
again.
patients pre-hospital who present with
Ah,
AFib with RVR, what percentage of them were included in this study?
100%. So in
Because
the ESO
I'm
data
interested
set,
in the
so we're filtering it,
population.
right?
Yes.
And the way they filtered this is they used the 2021 data
We
set,
should
and they
call
said,
Remley.
well, Rimley was not on this paper. Lawrence Brown was.
Okay.
So what they did is they said, in order, here's the consort diagram. We already threw this up and we already discussed it. So you had AFib RVR, you're a transport unit. They said, well, we're going to exclude you if you're really old, not very old. If you had cardiac arrest, trauma, fever, hypothermia, we're going to exclude those. They also
So that's
excluded
pre-hospital
sepsis.
data or ED diagnosis data?
Oh, you're asking about ED diagnosis. Hold that thought. This is all pre-hospital.
Okay.
They ended up with 135,000 that had AFib, and then they excluded those who didn't have RVR, and they used 110 as their cutoff.
Okay.
Maybe 150 would have been better. They did a sensitivity analysis at 150. So they ended up with 39,000 patients with AFib, broke those into those who had an intervention, 38,000, 5,000 who did not have an intervention, 5,000
So this
who
doesn't
did.
actually answer my question, because my answer is what proportion of patients with AFib with RVR. So everybody with AFib is 156,000.
That's how many people had AFib RVR, which is the 38,000.
Yes, but I want to know what percentage of the excluded patients were actually.
Well, you
in
can see that.
RVR.
There are 20.
But those are not, they don't necessarily have RVR. The ones they excluded them before you determined if it's AFib
Fair
with
point.
RVR. So the denominator
Yeah.
is the ones you're tempted to treat, which is you have AFib with RVR, and then what percentage, right? Because if the 20,000 who were
Okay, fair point.
excluded, right, it's very different proportions. If
Sure.
the 20,000
All right.
were
Fair-
excluded,
well, it's not that different a proportion, but it's
but if 80%
okay.
of
It's
them were
different.
actually in RVR,
Okay. Well, you're
then
right.
it would
We
be a
don't know
higher
because they
proportion.
excluded them. Fair point.
Yeah.
Fair point. Sometimes you have to do your own damn study. When you read a paper, you're that person that stands up at the abstract and says, "Excuse me, I have a comment."
no, like right, like this
What's
is
a good
clearly
point, though?
this is a
You have a
clearly well
different
done
question.
study, but I
Yeah.
think the question is, does
Your
the
question.
study answer
Not their question,
Does
but your
the study
question.
answer the question I want answered as a medical director when I say I'm going to add something to the protocol?
Fair point. So
This is like Lasix, right? Like the problem with Lasix is Lasix good for congestive heart failure? The problem with Lasix is we take care of undifferentiated respiratory distress.
yes. Well, I can't just say we got to go because she's kind of kicking my ass, and I have to. I know. All
I
right.
told your
Fair-
wife we're
fair
going to have
point.
dinner at 7.
Which was 10 minutes ago. Very important. So we're going to have to wrap it up. I was saved by Mikey. I appreciate that. I think, so is this sufficient evidence to say if you really hate AFib, treating AFib RVR, that this should change your mind? You might be like Dr. Sayre. We talked about this earlier, and he doesn't think dose VF is sufficient evidence to adopt, and I don't want to jump into that debate, but he doesn't think one prematurely closed RCT is enough evidence. I respect that. We're all going to have a different threshold. For me, this helps us along the way. I don't think this is conclusive. It is clearly hypothesis generating, which is all you can do from a cohort study. I think they tried to address the limitations as best they could, an appropriate use of propensity matching as opposed to, say, two completely different data sets. And they showed a mortality benefit, something I was not expecting.
I didn't expect that either.
Yeah.
I was
and
quite surprised.
no difference they showed a difference in transient hypotension only. No difference in prolonged hypotension that they defined as were they hypotensive at ED arrival. No difference in bradycardia, no difference in cardiac arrest. And you won't be surprised to know they weren't doing echoes to find out the EF.
Yeah,
and
to
they were
determine
still giving
diltiazem versus metoprolol.
87% of the interventions were diltiazem. 2% were cardioversions, the rest were beta blockers. I like the paper. I think it's a great paper. I think it adds to the data set, much like all of the people saying, Jeff, would you please shut up, you ignorant slut? So with that, guys, thank you all very much for tuning in. Great paper. Christy, thank you for reminding me about this paper, and I will see y'all next time. Thanks so much. Take care, y'all. Dr. Dorsett, thank you.
Hey.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.